You did talk a little bit about the role of dietary therapies and your recent study indicating that low FODMAP diet is not necessarily a good recommendation for many pediatric patients. What about just a general nutrition assessment with the family and the patient? You know, looking at the role of diet just in general nutrition in triggering some of their symptoms, their constipation or bloating or even pain.
It's a very good question. If you look at the studies that Dr. Chumpitasi has done in patients with IBS, more than a third have a trigger that they report, right? So you need to listen to the patients to try to see, what's triggering, to see if it's feasible to avoid some of those. We tend to be very careful in doing very restrictive diets, including, we have a nutritionist embedded in the program. You'd be surprised that many patients, we don't give a low FODMAP diet and we don't stress, and Dr. Snyder can comment because we're more worried about RFID than other psychological damage from the restriction. But yes, we always look at the BMI, we look at nutritional markers, and if we think there's nutritional deficiencies, we try to address that. But clearly there's studies in adults that have shown that a regular diet may be as effective as a low FODMAP diet in the treatment for these patients, but avoid more damage than good. On the other hand, if there's a significant trigger from the patients, you need to listen to them. And we work with them and we use it as a trial and try to rehab. But I would like Dr. Snyder to comment because this is a very hard topic, all these eating disorders associated with.
I think it's just something that we've learned to assess for too. In the same way that we're asking about any psychological symptom, we're also asking about disordered eating patterns, whether they've developed because of symptoms. Patients are worried to eat certain foods because they exacerbate symptoms, and then that results in them losing weight. Or we see many patients who do have a history of restrictive eating due to the fact that they have a negative perception of themselves as well. And so I think that's also where the guidance of a GI psychologist or someone who specializes in this too, because we also know that there's some medications that are sometimes prescribed by our medical colleagues that can result in weight gain or different side effects that could actually spiral a patient into a place that we don't want them to be. So we can also be helpful in sort of giving that recommendations back to the gastroenterologist when we're worried about those disordered eating patterns.
Yeah, the one that we're more worried about, and Dr. Snyder can say, ciprofloxacin seems like a very benign drug. Before we were very aware, we really precipitated major psychological problems by giving something as simple, quote unquote, as ciprofloxacin. So always step back and say, what am I really treating here?